From Rhode Island Public Radio and the Rhode Island Public Health Institute, this is Hepatitis C, Cost, Cure, and Challenge. We are live from the campus of Brown University in Providence. I'm Kristen Gourlay, and joining me now is Dr. Thomas Stopka from Tufts University. He is an epidemiologist who specializes in using geographic information systems to map the spread of disease. Welcome, Dr. Stopka.
Thanks very much, Kristen. It's a pleasure to be here.
Great. So there is evidence that the rising rate of injection drug use in this region, in the country, is fueling a wave of new hepatitis C infections. And I know that researchers are still just getting a handle on this trend, but what do we know about them and about this trend now?
Well, I can speak more definitively about the data in Massachusetts. And recent research showed a 78% increase in hepatitis C reported cases.
78%?
Yeah, 78% amongst 15 to 24-year-olds. Okay, so we're seeing rises particularly in a younger population in the past decade. Looking more broadly, in a study that looked at multiple states, in population of people who inject drugs under 30 years of age, there's about a 70% increase. And so this trend of increasing rates in younger populations we're seeing in places in New England, but it's also being witnessed in other places.
It's incredible. And so that's new infections, but also right now, I mean, we can't talk about hepatitis C without talking about the fact that people are dying from this disease right now, and they're dying in greater and greater numbers. I've heard directly from the head of the CDC's viral hepatitis division that some states have seen a 200% increase in deaths just over the past few years. And this is something that you have mapped, at least in Massachusetts. Tell us what you found.
Yes, along with one of my staff and students, David Myers, we looked at hepatitis C and HIV mortality and hepatitis C mortality between 2002 and 2011. We saw about 3,000 cases or 3,000 deaths tied to hepatitis C. Now that's probably vastly underreported because a lot of people are not diagnosed, and oftentimes when we do mortality data analyses, we're dependent on the coroner and the contributing cause and underlying cause of death that is reported, on the death certificate. But we are seeing increases in deaths over time. We haven't seen a huge significant increase, but we are seeing an increase in deaths. And I imagine it's only a matter of time if the treatments aren't applied broadly across populations that we may continue to see increases.
I wonder if you could zero in on a particular area or one of those hot spots that you found and just talk a little bit more about it. Give us a sense of what's going on, what kind of area you're talking about.
Sure. So we used geographic information systems and spatial epidemiology to look at clusters of hepatitis C deaths across census tracts in Massachusetts. And we found clusters of hepatitis C in South Boston, in Worcester, Springfield, New Bedford, the Merrimack Valley, which is in the Lawrence and Lowell area, as well as a few other areas. And so those are locations where we're seeing elevated clustering of deaths within the past decade attributed to hepatitis C.
What's going on in some of those areas in your estimation?
Well, injection drug use, relatively large populations of people who inject drugs. Some of those areas don't have syringe exchange programs and don't have perhaps adequate prevention programs. So places like Worcester, Springfield, Lawrence, New Bedford, where there are large populations of people who inject drugs, may not have adequate access to prevention programs.
Right. Your research also found that there were some racial disparities in the deaths. Can you talk about that a little bit?
Sure. We found that African American and Latino mortality rates were higher. as it related to hepatitis C, anywhere from 2 to 5 times higher rates of mortality compared to whites.
And these are people who've had chronic hepatitis C, one imagines, for a while, correct?
Yeah, and that's an important point. When we look at mortality data, we're looking at people who have died from hepatitis C, but who were likely infected 2 or 3 decades earlier, maybe more in some cases. So it's hard in looking at the mortality data to look directly at their risk factors, where they were when they were infected, and how they progressed. So that's one of the limitations in looking at mortality data. In some of our current research, we're starting to look at prevalence data, so people living with hepatitis C.
Mm-hmm. And we'll talk about that in a moment. Project ahead 10 years, 20 years from now, what are these hotspots likely to look like, or where would you expect to find them on the map?
My hope is that the costs of hepatitis C treatment will come down, and that broad treatment across folks who are infected will help to diminish the prevalence and incidence of disease. In epidemiology, one of our prime goals is decreasing the chance that a susceptible person can come into contact with somebody who's living with the virus. And so if the treatments can be applied broadly, I think, like we've seen with HIV, treatment as prevention can be very powerful. If the cost remains high, and if access to treatment remains challenging for a large swath of the population who's living with hepatitis C, we may see continued clustering. Some of the recent research shows increases in young, white, suburban, and rural populations as well. So that's another concern.
Right. And people who use illicit drugs are often going to find themselves involved in the criminal justice system. And that's why we have Dr. Michael Pashkas here. I want to thank you for joining us tonight, Dr. Pashkas.
Thank you for having me.
So you treat inmates in Rhode Island's correctional system, as well as at Thunder Mist Health Center. And I just want you to give us a sense, how prevalent is hepatitis C in Rhode Island's prisons?
Mm-hmm. Well, as we discussed, hepatitis C mirrors the same population with addiction, and that often brings people into the prison system. And as a result, the prevalence is fairly high in the population. Estimates range from 10 to 30% of the prison population can have hepatitis C at any time. The population is a fluid population and changes, so we could estimate that there may be 150 to 300 patients, inmates who currently have hepatitis C in the correctional system in Rhode Island.
And what about nationwide?
The prevalence continues to be at that point. So nationwide, it's a huge burden on the correctional healthcare system.
Right. And we have, about 2 million people within the criminal justice system in care at any one time, and 10 million or so cycling in and out. So that's a huge number if it's up to 30%, 40%.
Right. It is a huge number, and it's also, though, it's a huge opportunity to use that time when the individuals are incarcerated to do screening, to do education regarding transmission, and also to discuss options regarding vaccination to prevent other bloodborne pathogens like hepatitis B. And it's also recommended to vaccinate against hepatitis A and to do screening for HIV. And it's an important opportunity to link people into healthcare, especially when they get released from prison, which most of the individuals do.
Right. In fact, let's talk just a little bit more about this. This idea is gaining some more traction that, we could really make a dent in the overall epidemic if we really focused our efforts on treating and curing inmates right now. What's your opinion? Is that feasible? Set aside the money issue for right now. But
aside the money issue, I think that would be very feasible and would be an excellent way to start and to hit these hot spots, as we were talking. This is a population that is cycling in and out, that unfortunately they often relapse to addiction after getting released and will continue to spread this infection in the community. So this is a fantastic opportunity to potentially eradicate this infection addiction, and to really break this cycle of infection that we're going out into the community with addiction, addressing trying to help with their addiction as they transition to the community, but also it would be an excellent opportunity to break that cycle of hepatitis C if money were not an issue, but unfortunately it is.
It is, and we're going to talk about that some more. You're listening to Hepatitis C, Cost, Cure, and Challenge on Rhode Island Public Radio. We are broadcasting live from Brown University. I'm your host, Kristen Gourlay. And let's continue with you just a little bit, Dr. Poshkis. Even though it's theoretically possible to cure most inmates of their chronic hepatitis C now, financially, it looks impossible at this moment. I mean, I'd like to take 2 seconds to put this in perspective. The Rhode Island Department of Corrections pharmaceutical budget, their entire pharmaceutical budget is about $2.5 million. It doesn't take many patients at 84,000, 150,000, 94,000, whatever the course of treatment you're going with, to eat up that entire budget, right? So, but you've got sick patients right now. I was in a clinic with you when you were seeing one of them. How do you manage with this impossible math?
So what we've been doing is we've been trying to track all of the patients who have hepatitis C and are focusing on those who have more advanced disease. We're meeting with them individually, talking about the new treatment options that are available, and then we discuss it at a committee, and we try to match the same community standards. And so currently we're following Medicaid guidelines, sort of limiting it to those patients who have more advanced disease and are offering treatment to them. As we've seen, a lot of the patients have been there for many, many years, and they've failed previous treatments and have suffered
like
the
interferon.
consequences. Yeah, the pegylated interferon, and had suffered the consequences of the side effects associated with that, and their disease has progressed, and that continues to require often frequent hospitalizations related to that, cirrhosis, the potential for developing liver cancer. So the option of not treating it is quite costly also. So even though it's a large cost up front, we're really trying to, especially for the inmates who have a long sentence, that ultimately we need to address it.
Right. And you have started treating a small number of inmates, as far as I know, right?
Yes.
With these new drugs. And tell me your response to this. There might be some people listening who think, what if these inmates go out and relapse and get reinfected? I mean, is this a good use of taxpayer dollars? Because all of the money spent on healthcare in the Department of Corrections in Rhode Island is taxpayer money. Is that a good use of taxpayer dollars? How would you answer that? Mm-hmm.
Well, it is a public health emergency with this hepatitis C, and that the patients, while they're incarcerated, are being covered by state dollars, but often when they get released, they'll be either uninsured or on Medicaid and are still under state dollars and responsibility, and important to care for them. And so we continue to look for other options to help pay for this. HIV has been an excellent example for ways to do that with the Ryan White funding, and if there's a way to get increased federal dollars to help support paying for the medications during this opportunity while they're incarcerated, that would be an excellent resource of the dollars, and I think from a public health perspective would be very valuable also, in addition to treating their addiction. So hopefully they don't get reinfected, and the chances of them getting reinfected are very low, but especially if they were to get treatment for addiction after they get released, the chances of getting reinfected are very low, and I think the cost would equal out.
Let's bring you back into the conversation. Thomas Stopka, epidemiologist with Tufts University. So it's so clear from our discussion that hepatitis C and addiction, these two diseases are just intimately linked. And it's hard to know where to focus your efforts, your prevention efforts, even with limited resources. I wonder your thoughts. What more, perhaps, do we need to know in order to intervene at this moment with younger injection drug users, for example?
Yeah, I think that intersection of substance use, misuse, addiction, and disease that you highlighted is an important one. It's challenging for many of our colleagues in harm reduction circles, in syringe exchange programs, in clinical settings to get treatment on demand. Oftentimes, when somebody in the throes of addiction is ready for treatment, a drug treatment program, beds are not always available. Inpatient, outpatient slots are not always available. So certainly that's an important part of the equation, is trying to increase access to drug treatment, ideally on demand. Going after the highest risk populations with regard to hepatitis C is important. And that's where I think the work that we do in looking at hepatitis C hotspot clusters could help to guide public health decisions about the locations where intervention, where treatment, where prevention is particularly needed,
right.
And where maybe you'd see the biggest bang for the buck in the short term and long term.
Michael Pashkas, your thoughts on interventions we could be focusing on now from your perspective?
Well, I'm also a primary care doctor in the community, and a fair number of my patients suffer from addiction, and the balance of chronic pain and the overdose, the epidemic of deaths that we're seeing in Rhode Island related to that is really a challenge. And I applaud Dr. Fine and the health department in really tackling the addiction to prescription medications and this balance and trying to help develop pain medicine regulations for that. So I think as we improve trying to control the prescription of opioid and controlled medications by the providers, that's one thing. And then increasing the links to substance use treatment centers, such as methadone maintenance programs or inpatient treatment programs, that would be, I think, very valuable to help break this cycle and to help with the treatment of addiction also.
What's next for you in your research? I understand that you'll be looking at prevalence rates now. Can you tell me just briefly what you'll be looking at?
Sure, yeah. I'll be looking at hepatitis C reported cases between 2002 and 2013 in Massachusetts. There were about 90,000 cases that were reported during that time frame across Massachusetts. So we'll look at that information spatially and geographically to try to determine where the hotspots are for prevalent cases. And we're interested to see how the hotspots compare for people living with the virus to those who have passed away from the virus, and see whether there are any changes, because we can get at least a little bit closer to when the actual transmission took place with the prevalence data. Ideally, we want to look at incidence data and new cases moving forward as well, and how that spreads.
We will follow it, because this is something that no one really has a handle on yet, but there's growing evidence that it's going to be a problem. So I want to thank you both, Dr. Michael Pashkas with Thunder Mist Health Center and the Department of Corrections here in Rhode Island, and Dr. Thomas Stopka with Tufts University. We are going to take a very short break right now. You are listening to Rhode Island Public Radio. I'm your host, Kristen Gourlay, and together with the Rhode Island Public Health Institute, we are bringing you Hepatitis C Cost, Cure, and Challenge. We're broadcasting in front of a live audience here on the campus of Brown University, and coming up, we are going to meet a couple of women who are leading the battle against hepatitis C in Rhode Island. Stay with us.